Hi, everybody. Welcome to today's event. Happy Children's Day, first of all, to all the children. And the fact that we treat children on a daily basis as both pediatric and adult pulmonologists, I think it's a very great initiative by CCI to recognize an event on pediatric pulmonology and a pediatric topic today on World Indian Children's Day as well. So, thank you for inviting me to moderate this particular session, which is on childhood pneumonia. As all of you know, one of the highest cause of mortality in children all over the world is supposed to be pneumonia and gastroenteritis, which is one of the primary reasons why we focus on childhood pneumonia so severely at a national level, at an international level, even at the level of WHO. There are different types of pneumonias which affect our children. Initially, we did have bacterial pneumonias being the most severe. We're now moving on to atypical pneumonias, we're moving to viral pneumonias. And of course, this is increasing rather than decreasing across the world. So it's important for us as doctors to learn more about pneumonia, especially in childhood, because we need to understand that we can bring down our under 5 mortality rate. We can bring down our infant mortality rate if we treat pneumonia appropriately and early. So we have great panelists today who are joined us to discuss this topic. We have Dr. S Jayaraman from Chennai. We have Dr. Shreeja Nair from Navi, Mumbai. We have Dr. Hemant Agarwal from Lucknow, Dr. Vikas Sikri from Ludhiana, and Dr. Bala Raju from Vishakapatnam. All of these esteemed panelists are going to discuss today a lot of the questions that we commonly have with respect to childhood pneumonia. I would be very glad to moderate the session and answer a few of the questions myself and give my opinion as a pediatric pulmonologist. I do understand everyone in the audience are predominantly adult chest physicians, but it is you who will encounter a lot of these kids as well. And hence, it is very important that you learn this topic and treat the children to prevent the mortality. And I would probably be glad to answer any questions as a pediatric pulmonology point of view as well. So let's start off with our first session. The first session is by Dr. Shreeja Nair. So I invite Dr. Shreeja Nair to deliver her talk, and then we will continue after that.
Thank you, Dr. Bharath, for that wonderful introduction. Good evening, everyone. And before I start the talk, I would like to thank CCI. Thanks to Dr. Krishna, Dr. Atri, and the CCI office bearers for this wonderful opportunity. So my talk will be on pediatric pneumonia, the basics. And so let's start. So the scope of this talk is to define the community-acquired pneumonia in children. We will be discussing the other types of pneumonia in the panel discussion. We will discuss the risk factors for pediatric pneumonia, the epidemiology, how we diagnose pneumonia, and the basics of the treatment. So coming to a small introduction, we know pneumonia is defined as inflammation of lung parenchyma. It is a leading infectious cause of death globally among children younger than 5 years that accounts for an estimated 7.5 lakh deaths in 2019. Between year 2000 and 2015, the estimated number of pneumonia cases in Indian HIV uninfected children younger than 5 years reduced from 83 million to 49 million cases. That represented a 51% reduction in pneumonia cases. And in 2015, the incidence was greater than 500 cases per 1,000 children. 2 states, especially Uttar Pradesh and Madhya Pradesh, which still hold the highest record for the number of cases of pediatric pneumonia. However, in developed countries, we saw that the mortality from pneumonia in children have declined by 97% between the year 1939 and 1996, a decline that was largely attributed to the development of higher antibiotics and vaccines and expansion of medical insurance coverage for children. So what is the burden of pneumonia in children? This is a pie chart from the WHO that shows that pneumonia is a leading infectious killer of children worldwide. As you can see, 30% of all the infectious cases is due to pneumonia, and it causes nearly 1/3 of under 5 deaths from this infection. So let's define community-acquired pneumonia. What is community-acquired pneumonia? It is a lung infection that is contracted outside the hospital. It's an acute infection of the lung parenchyma in a previously healthy child acquired outside the hospital settings and not hospitalized within 14 days prior to the onset of symptoms. This excludes children with immunodeficiency, severe malnutrition, and post-measles state. Now, lower respiratory tract infection or LRTI includes pneumonia, bronchitis, bronchiolitis, or a combination of all three. The etiology is now divided based on the age of the child. So children younger than 2 years, as such, the pneumonia's cap in children is due to viruses most of the times. So in children younger than 2 years, we find that the main cause of community-acquired pneumonia is respiratory syncytial virus or RSV, followed by human rhinovirus and adenovirus. In 2 to 4 years, again, the main cause is RSV, followed by human rhinovirus and metapneumovirus. And now, as a child's age advances, we find that the bacterial infections increase. So 5 to 9 years, the most common cause is human rhinovirus, followed by mycoplasma pneumonia. And as the child grows, as the age advances from 10 to 17 years, the common cause is mycoplasma pneumonia, followed by viral infections. Coming to brief pathogenesis, so recent conceptual models postulate that pneumonia results from a disruption of complex lower respiratory ecosystem. That is a site of dynamic interaction between the potential pneumonia pathogens, the residential microbial communities, and the host immune defenses. So viral pneumonia usually results from a spread of infection along the airways that's accompanied by direct injury of the respiratory epithelium. This results in airway obstruction from swelling, abnormal secretions, and the cellular debris. The small caliber in airways in young infants, this makes patients particularly susceptible to severe infection. So atelectasis, interstitial edema, hypoxia due to VQ mismatch often accompany the obstruction. And viral infection of respiratory tract, as we all know, predisposed to secondary bacterial infection by disturbing the normal host mechanisms. It alters the secretions and also disrupts the microbial communities that reside in the respiratory tract. In bacterial pneumonia, when respiratory tract organisms colonize the upper airway tract and then gain access into the lungs, or as a result of direct seeding of the lung tissue in set of bacteremia, this is how bacterial pneumonia occurs. And when the bacterial infection is established in the lung parenchyma, the pathological process varies according to the invasive organism. For example, in a case of Staphylococcus pneumonia, we know that there is hemorrhagic necrosis, which can lead to formation of pneumatoceles and cavities, and subsequently suppurative kind of lung disease. A mycoplasma pneumonia usually invades the epithelium, it destroys the ciliary function, and can behave like a viral pneumonia. The pathologies of bacterial pneumonia include necrosis of the tracheobronchial mucosa, formation of large amounts of exudate, edema, and local hemorrhage, with extension into the interalveolar septa and involvement of the lymphatic and the pleural involvement. Coming to the risk factors of childhood pneumonia. So these are some risk factors which are mentioned, which worsen the morbidity and mortality in a case of childhood pneumonia. So a child who's severely malnourished, immunocompromised, has previous infections such as HIV or measles. If there's significant indoor air pollution, overcrowding, secondhand smoke where parents smoke, or if there's inadequate vaccination in infancy and childhood, these are all risk factors for developing pediatric pneumonia. Coming to the clinical features. So the typical symptoms usually start off with an upper respiratory tract infection with cough and rhinitis, and then progresses to symptoms of lower respiratory tract infection. So viral and bacterial pneumonias have moderate to high-grade fever. Now, unlike in adults, the main thing we look for in children is tachypnea or increased respiratory rate. So tachypnea is the most consistent feature of pneumonia in young children. Increased work of breathing that will be manifested by retractions, intercostal, subcostal, and suprasternal retractions. If there's use of accessory muscles such as the sternocleidomastoid, the scalenes, and the intercostals and abdominal muscles. And if there's cyanosis and lethargy, then it points towards the increased severity of infection. Auscultatory sounds, unlike in adults, are not sensitive for pneumonia in smaller children because you hear a lot of conducted breath sounds. So let's come to clinical features of different types of pneumonia. This is as per the IAP standard treatment guidelines of 2022. So a viral pneumonia usually follows short upper respiratory tract infection. It's a gradual onset cough. The child looks less toxic. If there's associated bronchiolitis, you may hear wheeze. And usually it's a bilateral disease that affects all lobes. If it's not complicated by any bacterial pneumonia, it lasts for 3 to 5 days and resolves spontaneously with supportive care. A streptococcus pneumonia, however, presents in a more toxic fashion. There's rapid progression and there would be lobar pneumonia. There are gastrointestinal manifestations also frequently reported. A staphylococcal pneumonia usually presents in a very toxic pattern too. So these children worsen very fast. There is hemorrhagic necrosis, like I said, so it leads to a suppurative kind of lung infection. You'll find multiple areas of consolidation which may cavitate, can form pneumatoceles, and form necrotizing pneumonia. If it bursts into the pleural space, it can cause empyema. And atypical pneumonia presents more like a viral pneumonia. Wheezing may be seen, and these children don't look that sick. So this can also be called a walking pneumonia. And there is diffuse lung involvement. So coming to the classification, this again is published in the IAP guidelines, but this is the revised World Health Organization classification of 2014 in children aged 2 to 5 years. So if a child just has cough and cold without tachypnea, we don't label this as pneumonia. We diagnose pneumonia based on the fast breathing rate. So more than 50 rates per minute in a 2-month to 1-year-old child, more than 40 per minute in a 1 to 5-year-old, or more than 30 per minute in a child more than 5 years, with or without chest indrawing or retractions, is diagnosed as pneumonia. And then the severity is graded based on other danger signs. So if the child is not able to drink or feed or has persistent vomiting, child becomes cyanosed, lethargic, unconscious, and gets convulsions, or if there's stridor in a calm child, or if the child is severely malnourished, these are children who have very severe pneumonia and would need admission. So whenever we see such a patient, we need to triage the patient. So how would we do that? We first recognize the red flag signs and then assess and then manage and reassess frequently. So by recognizing, we'll have to assess the airway, breathing, and circulation, check for the following points. If the child has an SpO2 less than 92%, is severely malnourished, is not feeding, is dehydrated, lethargic, unconscious, and has severe respiratory distress with grunting sounds, added sounds, and has tachypnea. So such patients you would label as severe pneumonia and hospitalize the patient. After hospitalization, you will start oxygen to maintain the saturation above 94%, give supportive treatment in forms of fluid, nutrition, paracetamol for fever, and do continuous monitoring of the vitals. Do the necessary investigations, including the chest x-ray, and start the appropriate antibiotics as per the guidelines. Then we reassess in 24 to 48 hours and see if the patient is improving or worsening. If the patient is worsening, you have to rule out complications like empyema or air leak, for example, in a staph pneumonia, and revise the treatment plan. So what are the diagnostic methods we use? So community-acquired pneumonia in a child is a clinical diagnosis, and we don't do any investigations in the OPD setting. It's a clinical diagnosis. However, if there are danger signs and the child needs to be admitted, once admitted, the patient has to undergo a CBC, blood culture, chest x-ray, and inflammatory markers in form of CRP and procalcitonin. And you can use molecular markers such as multiplex RT-PCR for detecting the organism. So a combination of CRP, procalcitonin, and CBC gives a better understanding of the treatment and the response to the treatment. And ELISA for antibody detection against mycoplasma is better than the cold agglutinin test. We have to keep checking the SpO2 with an pulse oximetry to see the severity as well as to monitor the response in the admitted child. So these are two pics showing the importance of radiology in an admitted child. Left, we have signs of consolidation ultrasound, and right, it shows an PA as well as a lateral view of an X-ray. We'll discuss all this further in the panel discussion. So what are the indications of hospitalization? So according to the IAP guidelines, it says less than 3 months, but some guidelines mention a child less than 6 months with pneumonia should also be admitted. If the saturation is less than 92%, if there's marked tachypnea, that is above the cutoff range that I said for the age. Severe malnutrition, patient is not feeding, is dehydrated, there's intermittent apnea or grunting, and if there's a failure of OPD management, then we admit the patient. So the treatment on OPD basis as per the guidelines is as follows. So you have oral therapy as I said before, in a child less than 3 months, you admit straight away. 3 months to 5 years, you start out. The first line is always amoxicillin, not co-amoxicillin, just plain amoxicillin at 80 mg per kg. However, the guidelines have said that the prevalence of penicillin-resistant pneumococci in India is less than 10%. So we can give a dose of 40 to 50 mg per kg per day. That's divided into PD dose. So, and same for more than 5 years. In the second line treatment, you will give coamoxiclav, cefpodoxime, or cefuroxime. And if staph aureus is suspected, then again, you give cefuroxime or coamoxiclav. It is also mentioned linezolid, but again, we all know that linezolid is an agent that we use for XDR TB, so it's preferably avoided. Once a patient is admitted, what do we give? The first line treatment for a child less than 3 months is cefoxitin plus minus gentamicin or amikacin, or you can just give ceftriaxone at the dose of 75 to 100 mg per kg per day divided into 2 doses. The second line would be piperacillin tazobactam with gentamicin or amikacin, or cefoperazone sulbactam with gentamicin or amikacin. And if staph aureus is suspected, you will add cloxacillin to ceftriaxone, or you give cefuroxime or cloamoxiclav with gentamicin or amikacin. And the second line for a staph aureus suspect would be ceftriaxone with vancomycin. In 3 months to 5 years, you start off with ampicillin, 100 mg per kg per day, that is twice a day, or the second line is coamoxiclav, cefotaxime, or ceftriaxone. And in a child more than 5 years, same, the ampicillin is the first line of choice, followed by coamoxiclav, cefotaxime, ceftriaxone, or azithromycin. So once a patient is stable and starts taking orally, then you have to change into you have to change from IV to oral as fast as possible. So in a patient who was receiving beta-lactam antibiotics, you change into amoxicillin or cefpodoxime that you give for 7 to 10 days. If it's a methicillin susceptible Staph aureus that you've detected, then you give cephalexin 50 mg per kg per day, twice or thrice a day for 7 to 10 days. If it's an MRSA, the choice is linezolid or clindamycin. If it's linezolid, which we're giving if we don't have a choice, we give for 14 days. If it's clindamycin with complications, then you give 4 to 6 weeks. So if there is no complications, 14 days, and if there's any complications such as empyema or suppurative lung disease, you take it up to 6 weeks. So when do we give macrolides in a patient? So we give macrolides only when the child is already immunized against Haemophilus influenzae type B, that's HIP vaccine, or pneumococcal conjugate vaccine, and there's no response to the first-line antibiotics or the suppurative complications are absent. If there's persistent of low-grade fever, cough, a few clinical signs, and the chest x-ray showing bilateral perihilar streaky infiltrates, we may give. And if the extrapulmonary manifestations are not suggestive of Staph aureus and there's no response to anti-staphylococcal antibiotics. So it's a symptomatic and supportive treatment only. And oseltamivir we give only in suspects and you have to give within 3 days. And in children less than 1 year old, the dosage is 3 mg per kg per day and twice daily. And more than 1 year, we go according to the weight. So less than 15 kg would be 30 mg twice a day. More than 40 kg, 75 mg twice a day. You don't give prophylaxis in children less than 3 months of age. And children more than 3 months, less than 1 year, you can give prophylaxis of OD dose of 3 mg per kg per day. What are the complications of CAP? So direct infection spread into the surroundings, such as pleural effusion, empyema, pericarditis can be seen. Or in a more serious fashion, it can go in as a hematological spread and cause bacteremia, septic meningitis, endocarditis, suppurative arthritis, and osteomyelitis. These are rare complications, but may happen in cases, especially in case of pneumococcal and influenzae type B infection. Staph aureus, strep pneumoniae, and strep pyogenes are the most common causes of parapneumonic effusions and empyema. How do we prevent CAP? We do that with vaccination. So there's good research-based evidence that vaccination in infancy and childhood reduces admission rate complications of pneumonia in children. So the recommended vaccinations as per WHO for babies and children are the pneumococcal conjugate vaccine, the PCV13, influenza vaccine, which has to be given for any child above 6 months, and also the household contacts, the HIP vaccine, H2 influenza type B, pertussis, measles, and COVID-19. This all will be discussed further in the panel. So I will conclude by saying a few points. The childhood pneumonia is preventable and treatable. We need early detection and initiation of appropriate antibiotics to prevent the morbidity and the mortality associated with childhood pneumonias. Malnutrition and immunosuppressed children are at higher risk of CAP. And rule out other mimics of community-acquired pneumonia, such as bronchial asthma, foreign body, recurrent pneumonia, etc. And we have to ensure a high vaccinational coverage for children and adults alike for prevention. Thank you so much. As we know, November 12th was World Pneumonia Day, and the theme this year was Every Breath Counts, Stop Pneumonia in its Track. Thank you once again. Now I hand over the screen to Dr. Jayaraman for his presentation. Thank you once again.
Very good evening. Namaste. I am Dr. S Jayaraman, consultant pulmonologist from Chennai. First of all, thank you very much, Chess Council of India, leaders, CCI Chairman Trustee, Dr. N.S. Krishna sir, Dr. Nair sir, and the President of CCI, Dr. Ashish Dubey sir, Secretary General, Dr. Anil Maske sir, CCI Webinar Coordinator, Vijaykumar Chetty, all the leaders of Chess Council of India, Dr. Kirat, Dr. Sumani Swami, Dr. Atri, all the leaders behind the screen. So thank you for this wonderful opportunity. Today, I'll be talking on establishing antibiotic stewardship in pediatrics. You all know very well, pneumonia is the #1 killer in children, for which each and every hospital has to have the antimicrobial stewardship program to minimize cost, to minimize adverse reactions, to minimize the drug resistance, a lot of benefit. So if you use left and right the antibiotic, the loss of side effects, drug resistance, we are facing a lot of problems. So for that purposes only, I'll be discussing on the antibiotic stewardship program. So thank you, moderator Dr. Bharath, and my previous speaker, Dr. Shreeja. So I'm talking on the pneumonia perspective of the antibiotic stewardship. Community-acquired pneumonia is a lower respiratory tract infection occurring in a child who has not in the hospital or a healthcare facility in the preceding 14 days. Pneumonia is the single greatest cause of death in children worldwide. Each year, more than 2 million children younger than 5 years die of pneumonia, representing 20% of all deaths in children with this age group. Why antibiotic stewardship? Antimicrobial resistance is a growing global public health. The overuse and misuse of antimicrobials are major drivers of AMR. Children are particularly vulnerable to antimicrobial resistance due to their developing immune systems, higher infection rates, and frequent exposure to antibiotics. In this context, antimicrobial stewardship in pediatrics is critical to optimize antimicrobial use and mitigate the risk of antimicrobial resistance. What is antimicrobial stewardship? The Infectious Disease Society of America defines AMS as a coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. AMS is a comprehensive approach to promote the appropriate use of antimicrobials by optimizing selection, dose, duration, and route of administration. Antimicrobial stewardship programs involve a multidisciplinary team that includes clinicians, pharmacists, microbiologists, infection preventionists, and other healthcare providers. What are the goals of pediatric AMS? Slowing the emergence of antibiotic resistance, eliminating unnecessary antimicrobial usage, improving patient outcomes, reducing healthcare expenditures, facilitating antimicrobial dosing adjustment and monitoring, enhancing timely transitioning from intravenous to oral antibiotics, optimizing total duration of therapy. When does a child or infant with community-acquired pneumonia require hospitalization? Children and infants with moderate to severe community-acquired pneumonia, including those with SpO2 less than 90%, infants under 3 to 6 months, and those with community-acquired MRSA should be hospitalized. Home observation concerns also warrant hospitalization. What are the common pathogens in community-acquired pneumonia in children? Viral causes due to adenovirus, coronavirus, human metapneumovirus, human rhinovirus, influenza A and B, parainfluenza virus 1 to 3, respiratory syncytial virus. Coming to the bacterial causes, Mycoplasma pneumonia, Staph aureus, strep pneumonia, Streptococcus pyogenes, all commonest culprit behind. What diagnostic, laboratory, and imaging test should be used with a child with a suspected community-acquired pneumonia in an outpatient or inpatient setting? The presumptive diagnosis of community-acquired pneumonia, which leads to indications for hospitalization. What are the causes of hospital? What are the indications? Anyone, respiratory distress or any hypoxemia or altered mental status, signs of dehydration, underlying conditions or comorbidities, unable to comply with the outpatient treatment. If anyone is yes, we have to go for the admission and diagnostic workup to start with the chest radiography, cultures mainly blood culture and sputum culture, gram stain, viral testing, viral panel as indicated with or without inflammatory markers like CRP and calcitonin, etc., PCT. And in patients, every treatment we have to start in the case of hospitalized patients. If we find any specific etiology, we have to adjust, de-escalate the antibiotic, otherwise to continue the empiric treatment. If there is no hospitalization requirement, so we can treat the patient as an outpatient empiric treatment. Which anti-infective therapy should be provided to a child with a suspected community-acquired pneumonia in outpatient settings? So patients younger than 5 years, presumed bacterial cause, the first line of antibiotic is the amoxicillin. Alternatively, we can use the amoxicillin and clavulanate. The presumed atypical cause, the first line of treatment is azithromycin, alternatively clarithromycin. In the case of presumed influenza pneumonia, oseltamivir is the treatment of choice. Patients 5 years and older, presumed bacterial cause, same like amoxicillin is the first line. Alternatively, we can use amoxicillin and clavulanate. The presumed atypical cause, first line azithromycin. Alternatively, we can use clarithromycin or erythromycin. Doxycycline for children older than 7 years is other alternative. In the case of presumed influenza pneumonia, oseltamivir or zanamivir is a treatment of choice. Which anti-infective therapy should be provided to a child with suspected community pneumonia in inpatient settings? So children with a fully immunized against Haemophilus influenza type B and step pneumonia, the presumed bacterial cause, start the first line ampicillin or penicillin G. Alternatively, we would use ceftriaxone or ceftoxin. Suspected community MRSA, we would add the vancomycin or clindamycin. In the case of presumed atypical cause, first line is azithromycin. Alternatively, we can use clarithromycin or erythromycin. Consider adding a beta-lactam if diagnosis of atypical pneumonia is in doubt. In the case of presumed influenza pneumonia, oseltamivir or zanamivir is a treatment of choice. Children not fully immunized against Haemophilus influenza type B or step pneumonia, the presumed bacterial cause is the first line ceftriaxone or ceftoxin. Alternatively, we can use levofloxacin. So used with the caution in the children who have not reached the skeletal maturity. And in our country, we have a TB endemic country, so we have to restrict the use of levofloxacin to prevent resistance. Suspect community-acquired MRSA, add vancomycin or clindamycin. In the case of presumed atypical cause, the first line is the azithromycin. Alternatively, clarithromycin or erythromycin. And doxycycline for children older than 7 years, levofloxacin for children who have reached the skeletal maturity. Presumed influenza pneumonia, oseltamivir or zanamivir. Coming to the individual organisms with the drugs, in the case of step pneumonia, preferred antibiotic is the ampicillin, 150 to 200 milligram per kg per day every 6 hours, or penicillin 2 lakhs to 2.5 lakhs unit per kilogram per day every 4 to 6 hours. The preferred oral treatment is the amoxicillin, 90 milligram per kg per day in 2 divided doses. Alternatively, we can use ceftriaxone instead of penicillin. In the case of intravenous medication, the dosages is the 50 to 100 milligram per kg every 12 to 24 hours. Streptococcal pneumonia resistant to penicillin, the drug of choice IV ceftriaxone, 100 milligram per kg per day every 12 to 24 hours. Alternatively, we can use ampicillin, 300 to 400 milligram per kg per day every 6 hours, or levofloxacin every 12 hours for children 6 months to 5 years. And we can use the linezolid also 30 milligram per kg. And we can use vancomycin also in a case of step pneumonia resistant to penicillin. Alternatively, we can use the oral levofloxacin or the other medications like oral clindamycin also in a dose of 30 to 40 milligram per kg in switchover treatment. Group A Streptococcus, the preferred is the intravenous penicillin. Alternatively, we can use ceftriaxone 50 to 100 milligram per kg per day every 12 to 24 hours. Switchover treatment preferred is the amoxicillin 50 to 75 milligram per kg per day. Alternatively, oral clindamycin we can use. Staph aureus, the preferred drug is cefazolin. The preferred oral treatment is the cefalexin. The alternatively, we can use clindamycin also. Staph aureus, methicillin resistant, susceptible to clindamycin. The preferred regimen is the vancomycin, 40 to 60 mg per kg, 6 to 8 hours interval, 6 to 8 hours, every 6 to 8 hours. Alternatively, we can use the oral treatment, oral clindamycin in a switchover treatment. Staph aureus, methicillin resistant to clindamycin, so choose vancomycin, 40 to 60 mg per kg every 6 to 8 hours. Alternatively, linezolid, 30 mg per kg per day, every 8 hours. Alternatively, we can use the oral linezolid also in switchover treatment. Haemophilus influenza, the preferred treatment is the intravenous ampicillin, 150 to 200 milligram per kg per day, every 6 hours. Or ceftriaxone, 50 to 100 milligram per kg per day. The preferred switchover treatment is the amoxicillin, 75 to 100 mg per kg per day in 3 doses. In the case of mycoplasma pneumonia, the preferred drug is the intravenous azithromycin, while switchover oral treatment with the azithromycin 10 mg per kg on day 1, followed by 5 mg per kg once daily on 2 to 5 days treatment. So, chlamydia trachomatis, the preferred regimen is the intravenous azithromycin 10 mg per kg on day 1 or 2 of therapy, and alternatively in switchover treatment preferred is the azithromycin. So, alternative is the clarithromycin. In the case of viral influenza, we have to choose the oseltamivir 75 milligram capsule, 60 mg per 5 ml suspension also available. In children less than 24 months, the 4 mg per kg per day in 2 double doses for a 5 days treatment. In adults, we have to use the 150 milligram per day in 2 doses. So other drugs are not freely available in India. How can resistance to antimicrobials be minimized? Limiting antibiotic exposure and using targeted treatment, properly dosed treatments for the shortest effective duration. What is the appropriate duration of antimicrobial therapy for community-acquired pneumonia? Treatment courses for 10 days are best studied, but shorter courses may be effective for mild disease. Infections caused by certain pathogens, notably community-acquired MRSA, may require longer treatment than those caused by staph pneumonia. Parapneumonic effusion or empyema in most children, antibiotic treatment for 2 to 4 weeks is adequate. How should the clinician follow the child with the community-acquired pneumonia for the expected response to therapy? Children on adequate therapy should show clinical and laboratory improvement within 48 to 72 hours. For children not improving within 48 to 72 hours of therapy of initiation, further investigation should be performed. To summarize, 5 Ds of antibiotic stewardship: right drug, correct dose, right drug route, suitable duration, timely de-escalation to pathogen-directed therapy are paramount important. These are all the references. So thank you very much for your patient listening. Over to moderator, Dr. Bharath, for further discussion. Thank you.
Thank you for those wonderful talks, Dr. Shreeja and Dr. Jayaraman. I think you literally covered everything about pneumonia in your short, crisp, and beautiful talks. I still think we should go through a lot of the practical issues that we face on a daily basis, with especially managing pediatric pneumonia. So I would like to invite all the panelists to join me today in discussing some of the practical problems that we face on a day-to-day basis in managing pediatric pneumonia as well. Let me start off with you, Dr. Shreeja. I know this has been discussed in the talk as well, but I think this is one of the common things that we face in OPD practice, right? A child walks in with cough, cold, regular fever. We definitely know that the child has an upper respiratory versus lower respiratory. Can you tell me, how do I differentiate whether it's upper respiratory, lower respiratory firstly? And if I think it's lower respiratory, when do I decide this child can be managed on an OPD basis versus an admission?
Yes, thank you, sir. So, good evening, everyone. Differentiating, like Sir said, a child usually comes with upper respiratory symptoms. So, unlike adults and children, the most common thing we look for is tachypnea and retractions and evidence of respiratory distress. So, unlike adults, children won't be able to give you the right history, and you have to rely a lot on parents' history and plus the physical findings that you find in a child. So, if you find the tachypnea is as the guidelines WHO as well as the IAP have mentioned, I find the IAP one the easiest, 50, 40, 30. So 2 months to 1 year, 1 to 5 years, and more than 5 years. So you know that if the respiratory rate is more than 50, you actually have to count the respiratory rate. Observe the child, distract him, but count the respiratory rate of the child. Look for any grunting sounds, accessory muscle use. Is the child lethargic? Is he responding? Does he look dehydrated? See the capillary refill if it's more than 2 seconds. If any of these signs are there, if there's signs of dehydration, the child is too lethargic, the respiratory rate is more than what is expected for that age group. If there's signs of respiratory distress, such as retractions and use of accessory muscles, you must check the SpO2 of the child. And if that is less than 92%, these are all red flag signs that you know that the child should be admitted. Other than that, if the child is not feeding, the mother will say an infant is not breastfeeding, is not taking the feeds, is lethargic. If there's any history of convulsions, I think these are the red flag signs, sir. And these are signs that the child has got lower respiratory tract infection as opposed to upper respiratory. And we should be cautious, and it would be better to admit such a child.
Thank you, Dr. Shreeja. Of course, we also do have certain pediatric scorings as well. We do have certain scorings, which are different scores, have different validity. I think in places where you see a large number of patients and we need to go through it very fast, using some of the scores are relatively useful. And the main criteria which many people use in the scores are respiratory rate as well as saturation, presence of the child's general condition is 3 of the main points that determine whether this child can be managed on an OPD basis or IP basis. So I think you covered that well. I think some of the scorings may be useful in children as well. Coming to you, Dr. Vikas, I think since a large number of the doctors here are adult physicians, Can you tell us what is the difference between adult pneumonia versus a pediatric pneumonia?
Good evening, everybody. Thank you, CCI, for making me the part of this panel discussion. So I'll say that the differences in response to the infection to the depends upon the airways and both the pulmonary parenchyma as well, and the difference could be just not anatomical but also immunological, where the immune system is not completely developed in the neonates and early childhood. And even the natural history of disease like pulmonary infection can be present a different way in both cases in early as well as the late stages. The upper ways are in the younger age group. The upper airway infections are more common as compared to the later in the life. Coming first to the anatomic differences, what are there? So as we know, the child is small. The airway caliber is also very small. So in these, the major airways are small, and the peripheral airways are still smaller as compared to the major airways. There's a minor amount of secretions or edema or inflammation in these group can lead to rapid compromise of the airways and retention of secretions. And other thing is the younger people or the kids or neonates, they have more number of mucus glands as compared to the adult population. So even the mucus production is more as compared to the elderly population. Third thing I'd like to highlight the anatomic difference is that the airways are very soft and pliable in these cases. Even if the kid tries to have a forced expiration or try to make an effort, that can lead to rapid collapse of the airways, and the collaterals are not well developed in these early the early life. So even the collaterals are not developed, that lead to rapid atelectasis and consolidation and development of more pneumonia faster as compared to the later. Other immunological differences, the immune system is not very robust in neonates and early life. So even the immunological response is not very good in these patients, and they can rapidly get into this loop of getting into severe infections.
Thank you, Dr. Vikas. It was very well summarized, the differences. I'd just like to add a few points here. One thing is, even in pediatric age group, we do see a big difference in the ages between children less than 1 year versus children between 1 to 5 years, 5 to 12 years, and above 12 years. So normally we differentiate everything, right from the physiology, right from the bugs, everything related to, even in children, this entire age group difference is definitely there. One of the differences that we see in the early age group, less than 1 year, and even in the neonatal age group, less than 2 months, is the gram-negative infections are relatively more common. And as the child progresses to get older, after the age of 2 months, we do see a large number of gram-positive infections. And after 12 years, we predominantly see atypical infections. So that is normally the chronology of how we differentiate the bugs which are seen in pediatric age group. With respect to the physiology, we of course see a large number of retractions is more common in children less than 2 years. So one of the main clinical presentations of two important clinical signs that we see in pediatric age group is grunting as well as retractions to identify pneumonia, which you may not see in an older age group. So that grunting and retractions are very red flag signs of children less than 2 years. We may not see that in children above 2 years. Now, why I mentioned about grunting as well as retractions is there's one particular condition which doesn't fall into the spectrum of pneumonia, but it's called bronchiolitis. So bronchiolitis is an exclusive condition that we see in pediatric age group, which we don't see in an adult age group at all. So bronchiolitis, as we know, is a viral infection caused predominantly by RSV, most commonly by RSV and rhinovirus. But these are children who come less than 2 years, come with tachypnea, come with the wheeze, but don't have significant retractions, look completely relatively happy, and they come into our OPDs with just wheeze as well as fever and mild infections. These are bronchiolitis infections less than 2 years. We end up managing many bronchiolitis on an OPD basis itself, and many don't end up requiring admission. So an important additional difference that we see in pediatric age group is the identification of bronchiolitis, which we don't see in the adult age group. And bronchiolitis is something that is a completely different topic, but is very, very common in children less than 2 years. And any child that we see with fever, mild cold, coming with retractions or heavy breathing and wheeze, bronchiolitis is our primary diagnosis before we make a diagnosis of pneumonia as well. So thank you for summarizing the difference between adult and pediatric. So I think we'll go ahead and ask Dr. Jayaraman one question as well. Dr. Jayaraman, I wanted to ask you, what are the other interventions do you think? Now, suppose this child has come in with pediatric pneumonia, or we're suspecting this child has some degree of pneumonia or some degree of LRI in the OPD practice. Dr. Shreeja gave us idea of when we need to admit this child. what is the interventions that you would perform next? Do you do X-rays? Do you do blood tests? What do you do after that?
Thank you, Dr. Bharath, for this wonderful question. First of all, I thank you, CCI, for this wonderful opportunity to take part in this panel discussion on pediatric pneumonia. So thank you. Coming to the question proper. So what are the interventions usually in a case of pediatric pneumonia? So in outpatient setting, 2-3 days fever, cough, cold. So we don't do any investigations, or simply we'll do the more than 3 days cough, fever, cold. We'll take X-ray and CBC and all. Interventions mainly in the form of taking CT and doing the bronchoscopy, take a sampling from the lung and send it for the biofire assay. This is mainly indicated in the case of severe pneumonia. Severe pneumonia with the red flag signs like desaturations and slightly tachypneic, tachycardia, drying of the chest. So these kind of conditions, so we admit the patients and we'll do the diagnostic bronchoscopy and send the specimen to diagnose what organism we are dealing with, whether it's viral or bacterial. We usually send the specimen for the biofire assay for the identifying the exact organism. This is the one way of diagnostic procedures. So we perform in our pediatric ICU or in the pediatric ward, laryngeal mask airway or intubation briefly and do the sampling technique. And in the case of pneumonia, with the complicated pleural effusion, in the case of empyema, child is tachypneic and very toxic. In that case, under ultrasound guidances, we do the pleural tapping and see any clear fluid or in the pus like pyothorax. If at all any pyothorax, we do tube thoracostomy under the image guidances and decompress the pleural cavity by relieving symptoms. This is one of the therapeutic procedures and diagnostic procedures we perform in a case of a pediatric severe pneumonia causing the complications. We intervene bronchoscopically as well as the tube thoracostomy for the diagnostic and therapeutic purposes. So this is the common interventions we perform in our pediatric setup. Yes, sir.
Thank you, Dr. Jayaraman. I think a lot of what you covered are cases of severe pneumonias and all the interventions that are possible in children with severe pneumonia. It covers the entire spectrum of that. Coming to you again, Dr. Vikas, I think one is we differentiate with adult and pediatric, but adding on to what question I asked to Dr. Jayaraman, do we need to do X-ray in all these patients? Every child who walks into the OPD, who are suspecting pneumonia, is there a role of doing chest X-ray?
I think the OPD patients, it's a diagnosis of clinical diagnosis. If the patient is not very sick, you're not planning to admit the patient, there's no requirement of doing the X-ray. That will expose the patient to not only the radiation, but also increase the cost of burden to the family as well. So as such, there are no clear guidelines, but yes, if the child is looking toxic, as you said, if this grunting is there, saturation on the lower side, and there's indrawing of the respiratory muscles, and on those cases, only toxic cases, we are trying to admit the patients. Yes, X-ray are helpful. It helps to differentiate us, whether it's a pneumonia could be a typical pneumonia or atypical pneumonia. Atypical pneumonia, as Dr. Shreeja has well documented, the presentation is, bilateral pneumonitis is there, and the lobar deficit is not there. In a typical pneumonia, patient might present with a lobar kind of consolidation, or complication of pneumonia could be picked up early if there's pleural effusion is there, or suspecting empyema. The complication can be picked up early if we do X-ray in the sick patients. Yes, routinely in the OPD patients, X-rays are not required and not recommended as well.
I agree with you that also considering the radiation exposure in the younger age group, we do consider, we look very carefully before going ahead and doing an X-ray. Dr. Balaraju, I would like to ask you a question on the role of complete blood count. What is the role of CBC in a child suspected with pneumonia?
Yeah. So coming to the point, yes, what we have discussed, because if the baby or the child is not toxic, so usually if it is a very short duration, usually you don't do any investigations unless and until you feel that the child is really toxic and if the fever is not coming down or if there is signs of worsening. If you find any of this, probably you will go ahead with the next investigation. And most commonest is what we do is the complete blood picture, CRP and the chest X-ray. These are the most commonest three investigations what we do. But if you are suspecting a severity of an infection, probably you will add all the other parameters like liver function test, renal function tests on all those parameters. But unless and until, it all depends upon the child. If the child is sick, yes, probably you will see. But if you pick up some other signs while examining the child, if you feel that it is a longer history, and if you're feeling that there is typical signs of a consolidation, and you're feeling the child is already sick with low saturation, retraction, all that stuff, probably you will do a complete investigation and admit the child.
Sure. Thank you, Dr. Raju. And I think also just adding 2 points to what doctors have mentioned as well, that yes, chest X-ray is not mandatory for children with pneumonia. Doing a clinical assessment and assessing the severity of pneumonia is definitely the frontline role. But you start seeing a patient, and we also encounter doctors coming from many peripheral places where they say X-ray may not be immediately available as well, or you need to transport the child a little farther away to do an X-ray. So in such cases, a lot of guidelines have mentioned the role of CBC. So there has been a study which has been shown, and certain guidelines which show that if the total count is about 20,000, then it is understood that there will be a patch inevitably on the chest X-ray. So this is the value which has been derived by a lot of studies and guidelines as well, that if we see a WBC count of more than 20,000, then the chance of us having a pneumonia is much, much higher. And the patch being there on the X-ray is found to be very, very high. So in such situations, yes, just doing a regular CBC in places, we're talking about resource-limited settings, wherein sending the child for an X-ray will be required to transport a child further. Do a CBC. If the counts are about 20,000, the chance of it having a patch on the X-ray is very high. Clinically treat and go ahead with your treatment. Going on to our next question to Dr. Hemant. Of course, we spoke about X-ray, we spoke about advanced interventional modalities. A new modality which is coming up right now is ultrasound chest, right? So I was talking about why should we do an X-ray, especially with regards to radiation exposure. So in such situations, is there a role of ultrasound chest in the diagnosis of pneumonia?
So good evening to all, and thanks CCI for giving me this opportunity. Regarding lung ultrasound, so nowadays it is the stethoscope of physician, because it is radiation free, less expensive. And important thing is that we can see immediately real time picture at bedside. In X-ray, we are getting X-ray in 1 hour, 2 hour. But the problem is it is not still included in that CAP guideline in children. And if we see about accuracy, I saw that meta-analysis and diagnostic sensitivity of is 95% with specificity 96%. So what to use, how to use, it depends on skill. But if we have skill, we can diagnose pneumonia as exactly as CT scan. So it's help in diagnosis consolidation by shred sign or some sign. And not only diagnosing consolidation, it differentiate what pneumonia, whether it's lower pneumonia, this is multiple patchy pneumonia, bronchopneumonia. And in fact, we can diagnose interstitial pneumonia, in that we can see B lines or itpil pneumonia we can diagnose. So not only diagnosis, we can do follow-up also. Suppose we are giving antibiotic and today we are doing ultrasound, and by next day or next 2 days, we can see whether our B lines are getting reduced or not, our consolidation size is getting reduced or not. We can identify complications in very early actually. We can diagnose that patient is developing pleural effusion or patient is developing some sort of empyema or some means that pneumothorax and lung abscess. So nowadays ultrasound is I think game changer to diagnose a pneumonia in adult as well as pediatric age group.
Thank you. I think that is a very important point that you made, that I think in the future, all of us as physicians need to be trained significantly in ultrasound, that we can probably use it in our OPD basis itself. And for me as a pediatrician, we feel that yes, the radiation exposure, which we're so worried about in children, is going to come down by the use of ultrasound. It's going to be a game changer, and we all need to start getting trained with ultrasound as well. But in certain cases, we may end up requiring to do a CT chest. And Dr. Shreeja, this question is for you as to when, in cases of pneumonia, would I go for doing a CT chest? Because of course I'm more worried. If X-ray itself is radiation, a CT chest is going to be more radiation. So, but there are certain indications that we do CT chest in children. So could you tell me what are the indications in pneumonia?
So CT chest, like you said, we would avoid as far as possible. But if a patient is not responding and we feel is worsening and is getting recurrent pneumonia, so you want to find out any other diagnosis that we've missed. Maybe patient has a foreign body. Are we looking at any heart disease? Is it pulmonary edema? Does he have any evidence of bronchopulmonary dysplasia? Anything that is not picked up by X-ray, or if the patch is not really properly visible on the X-ray and you want to grade the patch, how extensive it is. And I think another reason why we would do CTs if we want to bronchoscope the patient. So if we want to bronch the patient, we would want to know which segment we want to, access. So in such a case, you will need a CT scan. So other than that, of course, to find any further complications, even though ultrasound would give us most of the pleural complications, but things like pneumatoceles, abscess formation, these would be more clearer in a CT scan. So these are some of the reasons I would feel why we would do a CT scan.
Yeah, that's great. I'd just like to add a few of the other indications I commonly see where we do end up doing a CT scan. Like one you mentioned is presence of a persistent pneumonia. Persistent more than recurrent. These are children who come with a pneumonia patch, which is there on the X-ray. We treat them with antibiotics. The child goes home, comes back with the same patch. And every time we do the X-ray, it is predominantly in the same location. One of the most common suspicions for us always remains congenital thoracic malformations. Now, congenital malformations or congenital pulmonary malformations, either CCAM, bronchogenic cysts, or sequestration. These are the three most common congenital malformations we see in children. And inevitably, all congenital malformations do present as pneumonia itself. The first time they present to us is as a pneumonia. We end up treating them like a regular pneumonia. And then we start realizing there's something more sinister in this particular child's X-ray or the response to antibiotics. And that's when we subject them to a CT scan. So we also need to remember that many of your first-time presentations of congenital malformations will be in the form of pneumonia itself. And we need to have a low threshold to pick up congenital malformations and treat them accordingly after they come with pneumonia. The other condition where I end up doing CT a lot of cases with pneumonia is viral pneumonia, where these children present with a viral pneumonia and they end up continuing to have a persistent weight, a persistent oxygen requirement. So most of them tend to respond to our regular antibiotics, but the oxygen requirements don't come down. And they're always on a half liter, everything else is fine. But the child, most of the referrals which end up coming to me as a pediatric pulmonologist is these cases, where the doctor's like, we treat it like a pneumonia, but the child is not coming off oxygen. And then we end up doing a CT scan and we identify whether it's a post-infectious bronchiolitis obliterans or do we have any post-infectious complications after these pneumonias, right? So those post-infectious complications are something that we need to look out for, and a CT scan is the only way that we can look for a condition what we commonly call as post-infectious bronchiolitis obliterans, which initially all of them present like a pneumonia. The doctors were treated like a pneumonia, but they somehow feel that the child has not completely responded. So two conditions where we see a persistence of the patch, we're suspecting congenital malformations. And secondly, when we are suspecting that post this, the child is developing a complication as well. The other condition is, of course, whether we're suspecting tuberculosis or not. In children with pneumonia as well, we do need to consider whether tuberculosis is a possibility. If the child is not responding to routine antibiotics, there may be a history of contact. A lot of parents who have tuberculosis come to us with a child with pneumonia. Is this just a regular pneumonia or is this tuberculosis? Are the lymph nodes quite significant or not, right? That is where we need to do a CT with contrast to look for the lymph nodes as well in any child with suspected tuberculosis as well. So these are the three most common conditions I just want to add on where we end up doing a CT scan in children. Dr. Bharath, just based on the last point that I mentioned, right? When do I need to do this TB workup? Like tuberculosis, of course, we know is the most common infection in our country. We underestimate it in children because in adults, we always say tuberculosis is so common. In children, it is not that uncommon. Even with me being in a private practice, predominantly, we do see tuberculosis relatively common as well, even in the regular socioeconomic strata too. So when in a child with pneumonia, do I end up doing a TB evaluation?
The first thing what stuck my mind is what you said just now, because it is most commonest is the TB contact. Either the mother or the father will be a TB, open TB. So that's the main reason for the child to get pneumonia. One of the finding what I've seen getting a diagnosis of childhood pneumonia is doing a gastric lavage aspirate. I mean a gastric aspirate. So if you can get a good gastric aspirate and send it for a gene expert or a AFB, I've seen many cases positive with simple gastric aspirate because most of the children cannot get those, less than 1 year or 2 years cannot get that sample out. It's very difficult to do it. So in those cases, gastric aspirate is a very good because I was called to do a bronchoscopy, and by the time the gastric aspirate came as positive, and we didn't have to do any bronchoscopy to diagnose it as tuberculosis. So this is one of the main point what I've seen in diagnosing children with tuberculosis, especially. And what you said is correct. And a persisting patch in a chest X-ray, even after antibiotics, I think we should investigate for tuberculosis in India. Definitely. So, but it comes to this. So once you see a suspected tuberculosis, again you need to do a bronchoscopy to find out, get a bowel sample and do necessary investigations to diagnose as tuberculosis. So one of the other finding what I have seen is a recent transformation of man-2 positivity. The only problem with this is, yes, it is not very sensitive to only Mycobacterium tuberculosis. It can be positive with other infections also. But if you can do a interferon gamma assay, if you see a trend which is initially negative and later positive, definitely we can diagnose them as pneumonia cases, especially if they have a pneumonia with positivity.
Sure. Thank you. Just to add a few points as well, I agree with all that you said, but I think the role of MANTO as well as interferon gamma assay in pediatrics is considered very limited.
Yes,
We're
yes.
coming down, we don't usually, none of the guidelines, current IIT guidelines mention the role of MANTO also. So tuberculin skin test is completely going out of the picture. Why? Because in younger age groups, the effect of BCG on the tuberculin skin test is significant because the BCG vaccine is just given.
Yes,
We don't
yes.
base our treatment on the MANTO. But like you mentioned, a lot of our emphasis is still on gastric lavage. Now, a lot of gastric lavage aspirates do pick up tuberculosis relatively quicker. And just to add in addition, I agree, any form of contact, we need to obviously suspect tuberculosis. Persistent pneumonia, we suspect tuberculosis, not responding to regular medication. Just 2 points on the X-ray that we look for is if there's an increase in the subcarinal angle. If the tracheal angle, the subcarinal angle is increased more than 90 degrees, it is a very clear indication that we're suspecting tuberculosis in this particular child. If we see any form of mealy shadows on the X-ray, that is again when we suspect the presence of tuberculosis. So these present relatively early. We don't see cavitatory lesions in children. So this is another take-home point that a lot of us, as adult physicians, cavities are so common. In pediatric age group, we don't see cavity on the X-ray. We end up probably in adolescent tuberculosis we see, not in the early age group. But what we early see is the increase in the subcarinal angle. Anything more than 90 degrees, very clearly indication of tuberculosis. Any form of mealy shadows, definitely we suspect tuberculosis. And then we go ahead, like Dr. Bharath just said, doing a BAL and identifying the presence of your tuberculosis bacteria as well. So I think that is very important for us to not forget tuberculosis in our daily practice as well with pneumonia. Now, other diagnoses as well. So Dr. Jayaraman, we spoke about diagnosis of tuberculosis, but sometimes we want to look for other bugs. And biofire is something which a lot of people have started discussing of late. What is the role of biofire in the diagnosis of pneumonia?
Yeah, the role of biofire in diagnosing pneumonia. So the biofire test is, so we have to take the lung sampling in the form of sputum, or in children is very difficult to get a sputum, means so gastric lavage, or the bronchoscopic lavage, bronchial wash. We can send the specimen for the biofire, which includes the viral panel and the bacterial panel, atypical panel. We can pick up. So as early as possible, we can diagnose not all the patients, mainly in the case of severe pneumonia, despite medications, there is no improvement. In the ICU or in the pediatric ward with the medications, there is no improvement. Still, we have a dilemma. We are dealing with bacteria or virus or atypical organisms, no improvement, worsening clinical conditions, radiological conditions, and the other inflammatory markers are rising. In that cases, usually 5th or 6th grade, so we advocate bronchoscopy and the LMA with the anesthetists help. We do the bronchial wash and send it for the accurate diagnosis to clinch what exact organism we are dealing with. So this is the way we do biofire assay in our intensive unit as well as in the pediatric ward. Despite the treatment, no improvement, we go for the biofire assay. Not all the patients. So there are indications for the biofire assay to rule out and clinch the diagnosis. Yes, sir.
Definitely. I think the cost is one of the biggest factors that we have a problem with biofire, but thank you for elaborating the conditions where we use that. Another test which I think...
Bharath sir, Dr. Kishan sir, our chairman has put a message in our WhatsApp group. So far, 1,034 logins, the participants joined in our meeting. So thanks for Bharath for wonderful moderation and all the panelists. Thank you. Yeah, you can proceed, sir. Thank you.
Once we've spoken about biofire, the other common test which is coming up a lot is your throat swab for viral etiology, right? A lot of arguments are saying, should we really do it? Should we not do it? I think I'll ask Dr. Vikas this question. Dr. Vikas, what is the role of doing a throat swab to identify the viral etiology of any pneumonia?
Yeah, throat swab should not be done routinely. But definitely, in patients who are there's a high suspicion of infection early. Viral throat swab can be done to rule out if the patient is from endemic area or from if the family stays there, somebody is having infection at the home, then it's easy to pick up a viral infection whether to treat it or not. So throat swab can be done in the patients to pick up, if it's kind of history of background of COVID or background of H1N1. If it's seasonal is there, if you're suspecting around say October, November when the viral infections start early. Similarly, the change of season in March, April when the viral infections are picked up early. So this helps us not only to pick up the viral infection, it helps us not to give antibiotics to the children who don't require an antibiotic. So initially, patients have a short history of fever, sore throat, or difficulties in breathing early. So throat swab can give us an idea whether to expose this patient to antibiotics or not. And if the patient is not worsening, then X-ray and further things can be avoided. So antivirals now, most of the patients, these are self-limiting disease. We don't need to even to treat them. We just give symptomatic treatment for these patients. If it's a fever, a paracetamol is going to help the patient, or some decongestants are required for the upper respiratory symptoms. So we end up sometimes we use overuse of antibiotics can be prevented if we do a swab early.
Agreed. That is, I think, one of the main reasons why we end up doing throat swab. And as I mentioned, a large number of our children, less than 2 years, less than 3 years, end up being viral etiology, predominantly RSV as well as adenovirus. Even a recent study we've done in our hospital, we have shown that a huge chunk of the patients suspected as pneumonia and admitted ended up being either RSV positive or adenovirus positive. And that was the only role of us using a throat swab and preventing the use of antibiotic. We have seen an adenovirus surge, like you mentioned. Yes, we're looking at the seasonal outbreaks. We have seen a seasonal outbreak of influenza, very, very clear. Like with adults have influenza, the pediatric outbreak of influenza happens. But what we are observing is there is a huge seasonal outbreak of RSV as well as adenovirus. And the problem which happens with both RSV and adenovirus is there can be a certain degree of long-term outcomes which can happen once these particular viruses are there. So some of us do believe that, yes, if we have a chance of identifying these viruses, is there a role of us predicting the long-term outcome in this particular children? So Dr. Vikas, I wanted to ask you have you heard of the concept of whether adenovirus causes long-term effects? If so, can you elaborate for people who have not heard about it?
I'm treating most of the adult patients of pediatric. I've less exposure to the treating pediatric patients. So yes, I've heard complications, some lingering on complications, persistent cough and persistent. Patient can land up with some atypical features or persistent of oxygen requirement is there, but now we have not seen any patients. Such patients.
So I want to add a point mainly for the knowledge of everybody today, because this is something that we are seeing very commonly in pediatric pneumonias today, where a large number of them end up being adenovirus positive, especially children less than 3 years. And what happens is the children get treated for regular pneumonias, go home, but they end up coming back with recurrent wheeze. And these patients with recurrent wheeze have been misdiagnosed as asthma by many physicians, and they end up coming to us after the diagnosis of asthma. But the history is very classical. The child would have been admitted for a pneumonia at a certain point of time. And after that, the child has developed wheeze, which is recurrent and occurring literally every 2 months. The child is continuously on inhalers, continuously on nebulizers, but not being adequately treated. These are the classic presentation of what we call as adenoviral infectious, post-infectious bronchiolitis obliterans. So even in our own hospital, we have a caseload of almost 60 patients, which we have presented recently as post-infectious bronchiolitis obliterans, which are post-adenovirus. This is a very new upcoming entity which we need to identify. So if a child is less than 2 years, 3 years or 4 years, coming with everything normal, your CBC is normal, CRP is normal, X-ray looks relatively normal, the child has pneumonia and presents with a wheeze, with regular fever, we do need to suspect adenoviral pneumonia in these children. In certain cases where it's available, we can do a throat swab and identify these viruses. The advantage is that at that point in time, you're not going to treat anything. But later, a lot of children who develop RSV or adenovirus, nearly 50% of them become chronic wheezers. And how do we treat these chronic wheezers? Could either be in the form of either inhalers. Some of them in our cohort, almost 20% of them require IV steroids over a period of 1 year. And this is something which is coming up a lot because this is a new virus which is going to hit our pediatric age group very, very high. So just for the fact that I think a lot of physicians should not start being aware of this particular virus, which is coming up in children a lot. And the post-infectious complication is what we need to worry about. So coming to that concept of complications, Dr. Shreeja, I want to ask you, in case of inadequately treated pneumonias, let's say the child has been given antibiotic, but it may not be the correct antibiotic, it may not be the correct dose. What are the complications that we can encounter in inadequately treated pneumonias?
Yes, sir. So on the topic, viral pneumonias and atypical pneumonias usually present with the bronchiolitis obliterans, which is one of the most common complications, like you said. But the suppurative complications and the systemic complications are usually seen when there's a superadded bacteria or bacterial pneumonias as such. So you'd find that, for example, in a streptococcus pneumonia, you will find that it usually presents with a low-grade pneumonia. It can go into a necrotizing pneumonia pattern. That can also be seen in mycoplasma as well as Staph aureus too, and even in gram-negative infections. So when that worsens, a necrotizing pneumonia may lead into cavitation. It can burst into the pleura and cause empyema. That can cause bronchopleural fistula, and then that itself is another entity that we'll have to treat. Other than that, I think things we have to look for are even systemic complications. For example, things like Legionella pneumonias, which is very rare, less than 1%, but they come with symptoms of SIDH, dyselectrolemia. They can involve other, systems such as cardiac, renal, liver. So even in complicated COVID cases, it was very rare, but we have noticed cases of, multisystemic involvement in children in severe COVID infections, which can lead to organ dysfunction. So I think we have to be very prudent and watch out for these complications. Like you said, we have to diagnose early so that we can anticipate the problems. If it's just a viral, yes, mycoplasma viral, then they may lead into bronchiolitis. But if it's something like a strep, staph, gram-negative, such patients may worsen and develop a suppurative lung infection and have systemic infections. This is what I understand and what I've seen so far, sir.
Thank you, Rishi. I think that covers a lot of the complications that we encounter. And of course, our identification of these complications early will help us prevent long-term morbidity as well. But also identification of when children start going sick, right? So, Dr. Hemant, there's a question to you as to what are the red flag signs? Like, let's say I have a child with pneumonia, but what are those red flag signs which tell me that this is going bad? I probably, being a peripheral doctor, I need to refer this child to a higher center. I may need to refer this child to an ICU setup. So what are those red flag signs that we as peripheral physicians need to take care of?
Yes. Actually, when we are starting treatment for pneumonia, we have to watch whether the patient is getting improved or not, and we have to look for danger sign like patient after giving treatment, patient not able to take enough feeding, or patient not able to drink water, patient is getting dehydration. So patient is getting lethargy, drowsiness because sometimes that SpO2 is showing more than 92%, but patient is tired, he's not able to take enough breath, he's going for hypoventilation, raised CO2. So patient unconsciousness, patient getting central cyanosis, or sometimes patient getting severe respiratory distress, patient that will his head will getting nodding, and patient will have persistent tachypnea, patient will have stridor or persisting vomiting. Sometimes patient because of hypoxia there will be convulsions. So these are the red flag signs we should immediately send to hospital of a higher center for admission. So these are the danger sign.
Thank you, doctor. I think Dr. Hemant covered a lot of the signs and red flag signs. Please keep note of them because it is just a tipping point where the child can really go bad with pneumonia as well in our setups. So we need to identify these red flag signs and immediately refer them to a higher center like a PICU whenever we need them. Coming on to management, I think we covered a lot about when to diagnose, how to diagnose. I think Dr. Jayaraman covered the management extensively with respect to what antibiotics we use, what we should not use. Let me just add a few points in, which may be a little different than what he already discussed. The first thing is we talk about clindamycin. I think Dr. Jayaraman mentioned clindamycin staphylococcal pneumonia. But Dr. Shreeja, can you tell me why clindamycin is so good for staphylococcal infections? Is there something which it does additionally than just killing the bacteria?
So it's a leukocyte antibiotic. It has good penetration as compared to other antibiotics. That is what I understand, and it's used for MRSA infection per se. So, but it also depends on the resistance pattern in the community. So if we have clindamycin resistance of less than 15%, That is what is recommended in the guidelines as per the international guidelines. But our IAP strongly recommended to be used with as a once we detect MRSA, it is used as along with ceftriaxone or a beta-lactam antibiotic. So at a dose of up to 300 to 600 mg/TDS. That is what we follow. And
so the additional role, so the additional role, why
it has anaerobic activity too, right? So I think
correct. Yeah, but there is also an additional role in staph pneumonia. Specifically, why the IAP and other guidelines mention it very clearly is in staphylococcal pneumonias, there is a particular condition which we call as toxic shock syndrome. So toxic shock syndrome is something which is mediated by a particular toxin which the staphylococcal bacteria releases into the bloodstream. So a lot of children with staphylococcal infections, whether it's pneumonia or skin infections, this particular toxin gets released into the bloodstream, and that is what causes them to become toxic, become very hypotensive, requiring fluids, not feeding, etc. Clindamycin as a drug is shown to have a very specific quality to neutralize this toxin as well. So not only does it kill your staphylococcal bacteria, but it has a toxin neutralizing effect as well, which is why, of course, you treat all your regular staph pneumonias with your gram-positive antibiotics, but adding on clindamycin in sick children where they have a potential to develop toxic shock syndrome is considered very useful. So that is one of the additional roles of clindamycin in staph pneumonias. So some of these antibiotics do have additional roles, like Dr. Jayaraman. I wanted to ask you, in patients who have chronic lung diseases like bronchiectasis, we see children with bronchiectasis where we end up starting macrolide antibiotics as well. But here, I think the macrolide antibiotics play a different role. So a lot of patients come to me saying, why are you starting an antibiotic when he doesn't have a pneumonia? So what is the role of these macrolides in bronchiectasis?
Yeah, the role of macrolide in bronchiectasis. You all know bronchiectasis is an abnormal pulmonary dilatation of the bronchi, is a chronic conditions. So it's a chronic inflammatory condition which invite a lot of infections. So to prevent recurrent infections, so patient needs to take a long-term low-dose antibiotic treatment. The macrolide has a property of anti-inflammatory and infective therapy. It reduces the cycle of reinfection. Macrolide reduces the symptoms and improve the quality of life and reduce the exacerbation, thereby reduces the hospitalization. So the macrolide indications are very clear that in adult also we see a lot of patients with the COPD and bronchiectasis. This is the combo we see. The exacerbation etiology behind this kind of infections, if you start him on the long-term low-dose macrolide, so thrice weekly regimens, 250 to 500 milligram low-dose treatment for 6 months or 1 year, there is a dramatic improvement, less hospitalization because of the anti-inflammatory and infective property. It is one of the varaprasad of long-term infection control. So that's why the role of macrolide in a case of bronchiectasis cases and chronic lung disease. Yes.
Thank you for highlighting that point. As I mentioned, our antibiotics, we need to study them beyond just the antibiotic role or the role of killing bacteria. Like you mentioned, both our macrolides and clindamycin have additional role in treatment of these children who have chronic lung diseases and who are carrying diet bugs. Adding on to that point, of course, antibiotics are covered. What about other supportive treatment? I think Dr. Hemant can answer this question. Dr. Hemant, what is the non-pharmacological treatment? What are the supportive treatments that we can render for pneumonia?
Okay, sir. So everybody knows that antibiotic is the key role in pneumonia. But I have seen many children, those who are having chest pain because of maybe pleuritic chest pain or fever. And because of pleuritic pain, patient not able to take a deep breath. Patient is having shallow breath, tachypnea, later on muscle fatigue and type 2 respiratory failure. So in these children, we are supposed to give some antipyretic or analgesia to relieve the pain. If we relieve the pain, patient is able to take deep breath. And because of pain also, patient not able to cough out enough secretion, which may lead to mucus plug and later on complications. So that analgesia and antibiotics plays key role. Second thing is oxygen support. If patient is having tachypnea, chest indrawing, cyanosis, so we should supplement oxygen. The target is depends on means different target for given by different societies. Like most of the textbook, they says the target is 95% of oxygen saturation, but BTS says 92. So we have to keep saturation 92%, and the oxygen supplementation reduces mortality in case of severe pneumonia. But we should take care that if some patient is getting drowsiness, patient is tachypneic and saturation showing more than 95%, so that is red flag sign. Patient, we have to get ABG done, because these patient may have type respiratory failure, hypercapnia. So we need to give mechanical ventilation support if these patients are having type 2 respiratory failure. Another thing is IV fluids, because usually patients, they are sick, they are not able to take oral feed because of tachypnea, tiredness, risk of aspiration. So we have to take care of their dehydration part. And because of tachypnea and muscle action, they are having hypoglycemia also. So the ideal fluid is dextrose, matlab, dextrose containing fluid. But with giving of fluid, we have to look for IDH also, because this is a common complication case of severe pneumonia. So by the hand we are giving fluid, we have to avoid overhydration also because of SIDH. Another thing is chest fluid therapy, though it is not recommended for all patients. If the child is having excessive secretion and you are able to hear that gurgling sound, then you can give chest fluid therapy, by which that he can spill out secretion. And by removing secretion, patient will have increased gas exchange, reduced bulk of breathing. So
Sure.
it is not done routinely. And one more thing is that many patient, even parents, they are getting cough syrup from market, that open market or that. So we should counsel them that that patient should not take cough suppression, because once they will take cough suppression, it will drive the secretion and patient will not able to out that expect the sputum. So cough expectorant we can give if needed. So these are the supportive treatment other than antibiotics.
Thank you. Going on to an additional topic, which I think we touched on, Dr. Shreeja has touched on it, but this is something which is increasing again. These are atypical pneumonias. So, Dr. Vikas, can you tell me what are the bugs which are causing atypical pneumonias in pediatric age group? How do we identify them?
Basically, when we say atypical pneumonia, we are looking for pneumonias which do not have a regular course. The onset is more insidious, and the symptoms are less as compared to typical pneumonia. The mainly atypical pneumonia encountered in the pediatric age group are the mycoplasma pneumonias, or could be Legionella, could be chlamydia. So these are the basic three pneumonias which are seen in this child group, atypical pneumonias. Apart from this, sometimes these atypical pneumonias can have extra pulmonary symptoms also, as you already discussed the red flag signs in especially in cases of glandular pneumonia, where apart from the lungs, patient can develop renal failure also, maybe acute gastroenteritis and pancreatitis also. So these are the cases, atypical pneumonias which we need to look for in the pediatric or young children, or children and younger groups.
How do we diagnose them? Any role of any testing for diagnosing atypical pneumonias?
If atypical pneumonias, normally they don't require any, they are self-limiting pneumonias. But if the patient is not improving, the signs are lingering on for longer durations, then yes, we can go ahead with, if the patient is producing some sputum, we can go for sputum examination, or urine testing for Legionella can be done. And other PCR-based tests are also available, by like BioFire, if you want to test them early. So viral panels are available for BioFire also, and we can go ahead if the patient is not improving, the patient is sick and requiring ICU admission. So probably the key is to shorten the course, get the diagnosis as early as possible. So ELISA-based tests are there. Other tests like complement fixing tests are available, or immunofluorescence-based tests are also there. But if the patient is sick, then probably I think if the BioFire is available, that is can give us a quick diagnosis and also pinpoint the type of pneumonia we're dealing with, and the treatment can be started early in these patients.
True. Just to add one or 2 points to what you described, was the most common one which we see in pediatric age group is mycoplasma, compared to Legionella as well as chlamydia. Mycoplasma is relatively common. We tend to underestimate that. One of the clues for diagnosing mycoplasma is that the age group is very typically school-going children. We never diagnose mycoplasma pneumonia in children less than 5 years. Most of them are about 10 years. So this mycoplasma is a classic presentation. Most of them are your children about 10 years who are in the school-going population. They walk in with completely well, they're not at all sick, but we end up doing an X-ray for the persistent fever or persistent cough. They may just have fever and persistent cough. We end up doing an X-ray and we see a very big patch or a very big shadow there. And then we're completely stumped because the child is not at all sick. We admit this child, we end up treating them like a regular pneumonia. They're not responding to our antibiotics at all. that is when we start suspecting this is a mycoplasma pneumonia. So it's the classic presentation of atypical pneumonia that we see in our OPD practice as well. About 10 years, clinico-radiological dissociation and not responding to regular antibiotics are three factors to consider atypical pneumonia here. Of course, we don't need to test. We can directly start on treatment, but a lot of parents do ask us, how are you so sure it's mycoplasma? So there we do end up doing mycoplasma PCR. So right now, mycoplasma PCR is widely available, as well as mycoplasma IgM testing. So we usually send for IgM or PCR testing and then start on treatment. So let us not underestimate as physicians that mycoplasma is rare. It is very common, but please look out for it in those three particular case scenarios as well. So Dr. Balraju, let us say we diagnose atypical pneumonias. Can you elaborate a bit on the treatment of atypical pneumonia?
Yeah, thanks. Dr. Jayaraman sir has already discussed regarding the treatment part. So it's basically either it is macrolide sensitive or macrolide resistant. So initial drug of choice is definitely a macrolide, probably azithromycin to start with, or a clarithromycin. So, but recently there is high incidence of macrolide resistant atypical pneumonia. So there can be a role of doxycycline in these cases. But usually there is a taboo that you should not use doxycycline less than 7 years. But I don't think that's a major problem to use doxycycline. And one more drug can be used is a fluoroquinolone. Usually in children, we avoid fluoroquinolone as much as possible. But if it is necessary, yes, definitely a fluoroquinolone like levofloxacin or moxifloxacin.
Sure. And the other important infection that I think we should not underestimate, like I mentioned, we spoke about mycoplasma, is also community-acquired MRSA. So we have something called a CA-MRSA, where community-acquired MRSA is also going up. It is not something which you acquire only from the hospital. So community-acquired, we have done a few studies where we have shown community-acquired MRSA is upcoming as well in the pediatric age group. Dr. Jayaraman, could you just re-highlight as to, in these community-acquired MRSAs, what is our management strategy?
Yeah, the community-acquired MRSA, the treatment of choice is the vancomycin, 40 to 60 milligram per kg per day, every 6 to 8 hours. If the drug is not available in your place, you can choose clindamycin, 40 milligram per day, so every 6 to 8 hours. Alternatively, so we can give the linezolid, 30 milligram per kg per day, every 8 hours for children less than 12 years. If children is more than 12 years, we can give the dose of 20 mg per kg body weight. The MRSA duration of treatment is 7 days to 21 days, depends upon the extension of the involvement of the infection, whether it's a parenchymal infection alone, or it's a pleural infection, or pleuroparenchymal infection, is a unilobar or multilobar, depends upon the patient comorbid conditions and a lot of factors, multifactorial. So these kind of treatment, vancomycin, clindamycin, linezolid, so 6 to 8 hours dose, 7 days to 21 duration is very important for the community-acquired MRSA. Yes.
Yeah. And I think there's one question which is raised in the chat box with how do we calculate antibiotic doses in pediatric age group? I think like Dr. Jayaraman mentioned, a lot of it is calculated as mg per kg. We calculated whether it is IV or oral, it is always mg per kg, but whether we use it BD or in 2 divided doses or 3 divided doses, that is usually determined based on the drug that we use. So we calculate the total dose required for the day in mg per kg, and we either divide it into 2 doses, 3 doses, or OD dosing. Like macrolides, sometimes azithromycin, we give OD dosing. So we calculate mg per kg and then divide it into the dosing which is required per day itself. We've spoken about treatment, we've spoken about diagnosis. One of the things which is close to us should always be prevention as well. And being a pediatrician, immunization is extremely important for us. We advocate immunization and vaccination a lot. So a few words on vaccination as well. I think we can conclude with Dr. Shreeja telling us a bit about flu vaccine, and Dr. Jayaraman can add a point about pneumococcal vaccine and its prevention of pneumonias.
So, sir, I think I've elaborated some vaccines. So we have to give the flu vaccine trivalent or tetravalent. I think it depends upon the place where we stay. So the northern hemisphere, we usually give it in winters, but in the central and low south regions where we stay, we usually give it just before the monsoons. And it's important that you educate the parents early on about the vaccination, that it has to be given. It's an IM vaccine or a deep subcutaneous vaccine that is given for a child more than 6 months. And the whole family should take it. So the mother, father, the grandparents, everybody should be vaccinated. And this should be repeated yearly. So the child has to be called every year for the vaccination. And it is shown to prevent the, morbidity and mortality associated with influenza. So it's a very important vaccine. Other vaccines are the conjugate vaccine PCV13 that we must give again in the first year. And we have Hib vaccine, the Haemophilus influenza B vaccination. We cover DPT, pertussis, and diphtheria with the DPT vaccine. Measles, of course, is important. Other viral vaccines, these are the ones that I'm really aware of. And anything you would like
I agree. Those are the main vaccines we cover, flu as well as pneumococcal vaccine.
Dr. Any vaccine available for RSV, sir? RSV vaccine available in India, sir? RSV is available.
It's not come out in India, but definitely in the US, the RSV vaccine has started. But we also need to understand that RSV is a very big problem in the US, especially in premature babies. So there they end up, they have a particular seasonal trend for RSV as well. But what is weird and surprising is for the last year, we have seen an RSV trend in India as well. So there was an outbreak of RSV that we have documented. Most of us as pediatricians have noted RSV documentation in India, which means it will start in India as well. It's just that we have not been testing for it, so we didn't know it is RSV till now. Now that we're testing, RSV outbreaks are going to happen, and the RSV vaccine will definitely come into India as well pretty soon. So as we're running short of time, I'd like to thank all the panelists for covering all the questions so wonderfully and answering all the most common questions that we encounter in our daily practice. And I'm very glad to answer any more questions that you'll have. And over to Dr. Jayaraman to just give a few concluding take-home points from today's discussion to conclude today's session.
Thank you, Bharat, for this wonderful, nice moderation. So we enjoyed a lot of take-home points from this discussion. I thank you, Shreeja, Bala, Raju sir, Hemant, and Vikas. Wonderful discussion to commemorate Children's Day, Happy Children's Day today, and World Pneumonia Day. So we did a wonderful discussion. So the take-home points from today's discussion is that vaccination, pneumonia in general, is a preventable, treatable, and curable disease. The early diagnosis and treatment is a paramount important. So sensitize all the family members regarding the immunization in the children. Children almost they have 100% vaccination, but adult also there is a lot of lagging. So we have to teach the adult as well as children immunization very pakka. So whenever the vaccine is coming up, so we have to take as a first one. So prevention is better than cure, and appropriate diagnosis is very, very important. And we have to identify red flag signs. So any child with severe pneumonia, tachypnea, tachycardia, and restless, not able to take a proper feeding, and the indrawing of the lower chest wall, these are the warning signs. We have to hospitalize immediately with the meticulous care. We have to give like oxygen, IV fluids, and appropriate medications. But in so 2-3 days fever, cough, cold, no need of any investigations. So sometimes in people, children may end up with the complications of pneumonia like empyema. So we have to drain effectively by doing the ultrasound and other modality of investigations. CT, if necessary, we have to rule out. So certain conditions requires the bronchoscopy and the biofire assay. So indications are very clear cut. So these are all things we have to follow in practice. So don't miss anything, because in bronchopneumonia and diarrhea are the leading cause of death in children. So we have to meticulously address properly. So don't hesitate to refer the patients for the interventional pulmonologist for bronchoscopy or tube thoracostomy, and utilize the infectious disease specialist for the choosing antibiotics and other things and all. So this way we can update to have a healthy, happy children's life. So children are very important. So we have to take care. So with that messages, I thank you very much for Bharat for the wonderful moderation, and all the panelists for the beautiful correct address about the question answers. So thank you, CCI, for this wonderful opportunity again. I thank you, Krishna sir, Dan Pradip sir, founders of our CCI, and the Ashish Dubey, President, and Anil Maske, our Secretary, and Vishakapatnam, CCI Coordinator, and the pillars, architect of this CCI, Dr. Tadikonda, Dr. Shimani Swami, and Dr. Ravi Doshi, and Kirat ma'am, all the CCI is team behind a lot of people. So every Thursday we are enjoying different topics, different moderators, different panelists from a panel level. So thank you very much. Long live CCI. Thank you all. So good day. Thank you very much.
Have a good night, everyone.
Thank you. Thanks a lot.
Thank you.
Excellent moderation, Dr. Bharath. Thank you.
Thank you.
Wonderful.
Good night,
you.
everyone.
Learn a lot of pediatric things from you. Actually, yeah.
Thank you. Thank you. Good night.
Thanks a lot. Thank you.
Thanks a lot.
Good night.
Namaste. God bless.
Good night. Bye bye. Good night.